Hi, welcome to another edition of the author interview. I'm Bashar Qumseya with the Standards of Practice Committee, and I'm happy to be joined today by my esteemed colleagues and lead authors of the current guideline, which we'll be discussing today, Dr. Sunil Sheth and Dr. Jorge Machicado. And today we're going to be talking about our most recent ASGE guideline on the role of endoscopy in the management of chronic pancreatitis, which is published in GIE. Thank you guys for being here and thank you for your hard work on this very important guideline. Today we're discussing the management of chronic pancreatitis and the role of endoscopy, which is a very important topic for all of us who do advanced endoscopy. And it's also a very difficult topic to tackle with sometimes not a lot of evidence available. But as with all of the ASGE guidelines, we use the best available evidence based on systematic reviews and meta analyses and using the rigorous grade methodology to try to come up with the best recommendations that will help our patients and help our physicians achieve better outcomes. Thank you again for being here. I will go straight to the questions. Sunil, what is this guideline about?
Right. So this guideline is a follow-up after the initial ASG guideline that was not done by grade methodology in 2015. That was a fairly broad guideline addressing role of endoscopy in all benign pancreatic diseases, including acute pancreatitis, chronic pancreatitis, cysts, etc. Now, this guideline specifically focuses on chronic pancreatitis and management of pain and complications. And even though the evidence is not good, as you pointed out, we do provide important answers for controversial questions and management issues that most physicians and endoscopists struggle with in this very difficult disease. So specifically, what we're addressing is the effectiveness of role of endoscopy in the management of pain in chronic pancreatitis, including celiac plexus blocks, pancreatic duct stones, strictures, comparison with surgical outcomes, and then how we manage complications like benign biliary strictures as well as pseudocysts.
Excellent. Thank you so much for this summary. So let's dive in. You're in clinic, you're seeing a patient, they come in, you find that they have chronic pancreatitis and they have a dilated main pancreatic duct, which can be obstructed from a stricture or from a stone. And the question is, when do you do endoscopic management? When do you do surgical management? And how do you best achieve the outcomes you're trying to reach?
Right. So we are informed about our decisions based on the meta-analysis that we did on 6 studies, including 4 randomized control trials, specifically looking at patients who we feel had pain from an obstructed main pancreatic duct, either from stone or strictures. The poll number was only 199 patients. And what we found is that endoscopy was significantly inferior to surgery in terms of providing any pain relief, complete pain relief, ductal decompression, and improving physical quality of life. There was no difference in mental quality of life, survival, adverse events, and impact on endocrine and exocrine function. Now, it is really important to know that only 49, so less than 25% of patients had complete pain relief from either endoscopy or surgery. And this illustrates what we keep talking about, that the pain in chronic pancreatitis is multifactorial. Now, given such poor results, when someone fails medical therapy, ASG recommends that you do not proceed unless you have a multidisciplinary approach and you weigh the pros and cons of surgery versus endoscopy. And even though surgery is superior, most patients would prefer a less invasive endoscopic approach, and so would their surgeons. And some patients may not be even surgical candidates, either from contraindications, exclusions, age, or comorbidities. However, ASG does recommend that we proceed with endoscopy if we are confident and there's a high likelihood of relieving the obstruction or clearing the duct, because the data shows that if you can clear the duct by endoscopy, the pain relief is equivalent to surgery. So that's a subgroup analysis of who had good outcomes. Uh, so the corollary to that is that you cannot achieve endoscopic therapy when the tail of the pancreas is obstructed or you have dense calcifications. And if you do believe that that is causing the pain, then these people are more likely to go to surgery. So basically, what we have to do is that ASG recommends that if medical therapy has failed, consider early surgical evaluation and proceed with endoscopy when you have a high likelihood of clearing the duct, or if the patient has a preference, or if there are contraindications or non optimal surgical candidates.
Excellent, excellent. So basically, for this clinic case we're talking about, you saw the patient, you think they may be a good surgical candidate, they don't have a lot of comorbidities, there's no obvious contraindications. The next step would be to get a second opinion from a surgeon and get then the preferences from the patient, the surgeon, and yourself based on the location of the stricture or the stone, and to decide what to do if ERCP would be helpful. Thank you so much. So
Yeah.
this is a very, very important clinical scenario. Okay, we'll go to Jorge here. Jorge, so we decide that we do want to proceed with the endoscopic management. What are the different kind of management options that we have based on stone size, location, and radial opacity of the stone?
Absolutely. So for this, we conducted a systematic review and meta-analysis that included four studies in total. One of these was an RCT that was comparing basically doing ERCP or not in all patients who had S-well, and the other studies were all observational. So basically, for this question, what we did is, as a panel, we had to discuss about all the different options that we had available and all the different factors that can impact the treatment response. So when we treat pancreatic duct stones during ERCP, we have conventional methods such as sphincterotomy, balloon extraction, basket. We also have the use of pancreatoscopy, for which we can use electrohydraulic lithotripsy or also laser lithotripsy sometimes. There's also baskets that have been developed that can allow us to remove stones with pancreatoscopy. And in addition to endoscopic methods, there's also the use of external shockwave lithotripsy, for which we can fragment the stone using equipment externally without necessarily using an ERCP. In addition to that, the stones can be radio opaque when they can be seen on X-rays like white color, and then radio lucid as well, in which we don't see them very well, and can be located in the head, neck, body of the pancreas, different locations. So, taking all these factors into consideration, the HSGE has a conditional recommendation based on low quality of the evidence that for radiopaque stones that are small, less than 5 millimeters, or any radiolucent stones, to go straight to an ERCP. And in that situation, either with or without pancreatoscopy based on our pancreatography findings. Now, for any patient who has a larger stones than 5 millimeter that is radiopaque and that is located in the head, neck, or body of the pancreas, the ASG suggests either to use ERCP with or without pancreatoscopy or using S-well alone. So I think that for this specific question, we have to consider the availability for the centers. Many centers do not have access to as well, while pancreatoscopy is slowly being more accessible in many places in the United States. Although we currently do not have high quality data with randomized controlled trials, there is a ongoing multi-center RCT that hopefully will answer the question between as well and pancreatoscopy with EHL for treatment of pancreatic duct stones. Now, when we select as well, we also, the HSGE suggests do not use ERCP routinely after we perform it, unless there is a lack of spontaneous clearance of the fragments that we define as a presence of fragments of 2 to 3 millimeters. So after doing as well, doing images, if the fragments have not fragmented enough, then ERCP would be okay. Otherwise, as well alone is appropriate.
Thank you, Jorge, for an excellent summary on this very difficult topic. And these recommendations can be found in our summary of recommendations as highlighted by Jorge. Thank you so much. All right, Sunil, back to you. So now
Yeah.
we've decided a patient, we've talked to the surgeons, we've talked to the patient, we want to proceed with an ERCP. We're doing the ERCP, and then we're deciding about stents. Can you tell us about the number of stents and the type or diameter of stent that we should use in this case?
Right. So once again, amongst all our guidelines, this is probably the one that has the lowest quality of evidence, which is based on a handful of observational small number studies. But given that it's a very difficult question, we are still trying to provide a conditional guideline for this. So the first question is using plastic stents for what we think might be painful dominant strictures. And if you're going to place a stent, this observational study was trying to answer the question whether you put one stent upgrade to two, or start with two. And these were small numbers, but what the study showed is that if you have a single stent, your rates of pain relief are the highest compared to multiple stents, and the number of patients that got pain relief in this group was also higher. All the other outcomes were similar. Then, in terms of the size of the stent to use, again, a single observational study comparing 10 French stents to 8.5 or lesser stents. And what this study showed that is if you have 10 French stents, you're less likely to have hospitalizations per patient for pain in the larger stent group, and also the number of patients are lower. So combining both these low quality things, if you have an initial treatment of a dominant, presumably painful stricture and chronic pancreatitis, and you decide to proceed with endoscopic therapy, then you should proceed with a single plastic stent of the largest diameter that is possible that can be safely deployed without any forceful placement.
All right, excellent. And then on further follow-up, you should try to upgrade to the largest possible diameter, correct? So let's
Correct.
say you started with a
Right.
5 French,
Right.
maybe the next time you can go up to 7 French and so on.
Correct.
All right.
So that begs the question on, you start with an initial treatment, but if the stricture persists, there are various definitions that are used in various studies, such as persistent stricture being something that is present 3 months after initial stenting. What they define as refractory is after 1 year of stenting, there is still a painful stricture left. And this is where metal stents come in. People have used in observational studies, single arm studies, sometimes a comparative study comparing single plastic stents when persistent with the metallic stents. In refractory cases, they've compared multiple plastic stents with fully covered stents. And basically, what we found is that plastic stents are equally efficacious as metal stents with similar immediate side effects. However, unfortunately, with metal stents, the delayed side effects are enormous, with almost 50% stent migration rates and 8 to 10% secondary de novo strictures developing. So, based on questionable efficacy and significant delayed side effects, the ASG currently does not recommend the routine use of metal stents in the pancreatic duct for pancreatic strictures until better evidence is available.
Excellent. That's very important. All right, so we're going to use a single stent. We're going to use the largest diameter possible and keep upsizing on the next time. And we're going to avoid using metal stents. Excellent. So one last question, which is clinically relevant. So somebody comes to you, they have chronic pancreatitis, but they have biliary dilation associated with maybe cholangitis or elevated LFTs, bilirubin. What is the best approach in these patients? Metal stent, plastic stent? What did we find?
Right. So, first of all, it's important to determine that the biliary stricture is symptomatic. And symptomatic biliary strictures with chronic pancreatitis are those that are associated with jaundice, as you pointed out, or elevated alkaline phosphatase for more than 4 weeks. Anything less than that is considered acute and could be spontaneously reversible. So, once you exceed 4 weeks, it is important to address the stricture because the risk of secondary biliary cirrhosis is quite high. And then the way you do it is either you can put multiple plastic stents or you can put a single fully covered metal stent. And this question was answered by a meta analysis that we performed on 3 randomized controlled trials, including 250 patients. And what we showed and in our data is that multiple plastic stents are equally efficacious as a fully covered metal stents in terms of stricture resolution, pain relief, time to resolution, and adverse events. However, the most important thing was that with metal stents, there was a median of 1.5 less ERCPs in patients who received metal stents compared to plastic stents. So, based on this data, ASG recommends that we consider placement of fully covered metal stents for symptomatic biliary strictures before multiple plastic stents, especially if there is concern for non-compliance, because you cannot leave multiple plastic stents indefinitely in place if there are compliance issues, because serious complications can result.
Excellent. And lastly, I'd say that there's some associated risk of increased acute pancreatitis if you put metal stents, but this does not appear to apply to this patient population.
Right. The risk of pancreatitis is low.
Thank you so much.